Hey everyone, welcome to this explainer. Today, we're totally transforming how you might look at your role in healthcare. We're diving into quality improvement in vascular access. Now, I know it is incredibly easy to get bogged down in the day-to-day tasks, right? Inserting lines, changing dressings, clearing occlusions. But today, I want you to take a step back and look at the bigger picture. I want you to view the vascular access clinician not just as a highly skilled technician, but really as a clinical detective. You're the one looking at the systems, analyzing the evidence, and constantly asking, how can we do this better, safer, and more efficiently?
So that brings us to the ultimate question we're trying to answer today. How do we actually bridge the gap between knowing the best practice and doing it? We all know evidence-based guidelines exist. We know what the textbooks say. But, in the pure chaos of a real-world clinical shift, how do we make sure those best practices actually reach the patient every single time? Well, that is exactly what quality improvement does. It shifts our focus from just memorizing clinical facts to actually building the systemic improvements that drive real, lasting patient safety.
Okay, let's dive into this. Here is our roadmap for today. 1. Defining quality improvement. 2. The PDSA cycle. 3. Root cause analysis. And 4. Tracking meaningful metrics.
Starting with Section 1, defining quality improvement. What exactly is it?
According to our sources, quality improvement, or QI, is formally defined as the initiation of actions to improve or strengthen patient care through ongoing monitoring and assessment of performance measures. Now, I really want you to focus on two words there: actions and ongoing. This isn't just some abstract administrative jargon discussed in a boardroom. It's a highly active, continuous, boots-on-the-ground process. It's fueled by objective data to evaluate patient outcomes. It's all about looking at how we deliver care right now and finding measurable ways to strengthen it. But we can actually take this a step further. We hear QI a lot, but we also hear continuous QI. So what's the difference? Well, standard quality improvement tends to focus on specific clinical aspects of care, like a single task or maybe a localized issue. Continuous QI, on the other hand, broadens that focus. It encompasses all the organizational facets and interdisciplinary processes that affect patient outcomes. It recognizes that vascular access doesn't happen in a vacuum. It involves internal folks, like your fellow employees, and external customers, like the patients themselves and third-party payers. Everyone's input is valued. Now, what's really interesting about this slide is this colorful steps to quality improvement wheel. It shows how the entire lifecycle of a QI project relies heavily on process mapping and workflow analysis to truly understand a problem deeply. You start by identifying the issue, setting measurable goals, and looking at structural factors. Then you design your improvement plan, roll it out, and continuously assess your progress. Because it's a continuous wheel, the end of one project is often just the new baseline for the next.
Moving to Section 2, the PDSA cycle. This is all about testing your hypotheses.
The PDSA cycle is basically the fundamental method we use to systematically test solutions in real time. It stands for plan, do, study, act. Think of it as the scientific method, just miniaturized for the clinical floor. You plan a change, you do it on a small scale, you study the results to see if it actually worked, and then you act on what you learned, either by adopting the change, abandoning it, or tweaking it and running the cycle all over again. And this brilliantly illustrates how we apply this to a concrete clinical example. Let's say your unit is dealing with high PICC occlusion rates. Step 1, plan. You hypothesize that standardizing the flushing protocol will help. Step 2, do. You implement this change on your unit. Step 3, study. You measure the occlusion rates before the intervention and compare them to the rates after. Do the numbers go down? Step 4, act. The data says yes, absolutely. So you act by adopting this protocol and rolling it out hospital-wide. That is QI in a nutshell. On to Section 3, root cause analysis. What do we do when things go wrong? Historically in healthcare, when a mistake was made, the immediate reaction was to assign blame. Who messed up? But focusing on individual failure frankly just creates a culture of fear where frontline workers might hide their mistakes. Root cause analysis completely flips the script. It shifts the focus entirely to systems improvement. Instead of asking who failed, it investigates how the interdisciplinary processes broke down. It assumes that good people are working in flawed systems, and our goal is to fix that system to prevent future errors. To do that, the root cause analysis boils down to 3 essential yet deceptively simple questions. First, what happened? You just gather the objective facts without judgment. Second, why did it happen? This is where visual tools like fishbone diagrams are super helpful to peel back the layers and identify systemic breakdowns, like maybe an unclear instruction manual or the wrong supply being stocked. And third, how do we prevent it? This is where you design your system-level safety net. I want to pause on this quote directly from the source material. It's about systems improvement, not blame. This is absolutely the cultural and ethical heartbeat of quality improvement. If you're a vascular access specialist, part of your professional development is leading these initiatives. You have to be the champion of this mindset. When an adverse event occurs, like a CLABS or a major device malfunction, you are the one who steps in to humanize the data, remove the stigma of human error, and guide the team toward a systemic solution. Finally, Section 4, tracking meaningful metrics, using your data as proof. In Vascular Access, we have to track specific outcome metrics. We're looking at CLABSI rates, monitoring device dwell time, tracking first attempt success rates, monitoring occlusions, and auditing dressing change compliance. And listen, this isn't just busy work. This data is often visualized on unit compliance dashboards and run charts to provide absolute, concrete proof that the interventions we test in our PDSA cycles are actually succeeding. So, the crucial point is this. Tracking all these metrics, mapping our processes, conducting root cause analyses, running PDSA cycles, it all serves three ultimate goals. We are trying to improve safety by preventing errors before they reach the patient. We are trying to enhance patient outcomes so folks heal faster and experience less pain. And we're trying to maximize efficiency, making sure our time, supplies, and healthcare resources are being used as effectively as possible. That is really what it means to be a clinical detective. You have the tools now, the definitions, the PDSA framework, the RCA investigation questions, and the specific metrics to track. The only thing left to do is apply them. So I'll leave you with this lingering question to think about before your next shift. What metric will you improve on your unit tomorrow? Thank you so much for exploring this fascinating topic with me, and keep advocating for your patients.